Let's wait a minute. All right. Good morning, everyone, and thank you for attending our Grand Rounds lecture today. Today's lecture is courtesy of the Natalie and Jack Congdon Visiting Scholar in Cardiology. This scholarship was established in 2010 by Natalie and Jack Congdon, and it enables the VCU Pauley Heart Center to attract a number of talented cardiologists. After his service in the Army, Jack helped build the family trucking businesses of Old Dominion Freight Line and Old Dominion Truck Leasing. Jack was a proud supporter of the Massey Cancer Center and the Pauley Heart Center. Jack and Natalie passed away about 10 years ago. They had 3 children, and their son John continues to support the Pauley Heart Center as a donor and advisory board member. I'm pleased to introduce to you our speaker for today, Dr. Payman Zamani. Dr. Zamani is an assistant professor of medicine in the Advanced Heart Failure and Cardiac Transplant section of the Perelman School of Medicine at the University of Pennsylvania. In addition to seeing patients, Dr. Zamani has an active research program focused on understanding the limitations to exercise in heart failure patients and how these can be improved, with a focus on the skeletal muscle. Dr. Zamani graduated from Dartmouth College and received his medical degree from Harvard Medical School. He completed internal medicine training at the Brigham and Women's Hospital and his general cardiology training at the University of Pennsylvania. He received additional training in advanced heart failure and transplant cardiology at the University of California. We're grateful for Dr. Zamani's expertise on this topic and look forward to learning from him. At the end of the lecture, we'll leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We're pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and end of this presentation to 804-625-4041. I'll now turn it over to Dr. Zamani.
Thank you. One request, is it possible to minimize that so that it's not on the right side?
I think there is, right? Yeah.
I have to stand over here to use the clicker to go forward?
Try now.
Oh, there you go. So there's the CME code for people who need it. I'll wait a moment here. Thanks for having me. These are my disclosures. Okay, so let me just get right into it. So we'll be talking about heart failure with preserved ejection fraction, a condition that has been enigmatic for some time right now. Do you need the, am I not loud enough? Am I loud enough? Or do you want to? Do you need me over there? Probably, thank you. Okay, so what we know, what we think we know, this condition is only growing in incidence. So the newest reports out of Framingham predict that a lifetime risk of heart failure is about 1 in 4 individuals who will get heart failure. The lifetime risk for HFpEF is about 10%. So I bring this up just briefly by terms of epidemiology. We're talking about a lot of patients. And by 2030, it's estimated that in the US, the HFpEF, the heart failure rather, population will be over 9 million individuals. But for the purpose of this talk, this is the central issue. Patients with HFpEF are markedly limited in terms of what they can do. And we measure that using something called VO2, or peak oxygen uptake. It is the gold standard metric of aerobic capacity. And across several studies, peak VO2 in HFpEF patients was around 15 mLs per minute per kilogram. Well, why is that important? Well, if you let your eyes gloss across, we have several just routine things that people do in their day-to-day. Dressing, light housework. These take up gigantic percentages of what a HFpEF patient can do. And importantly, as shown over there, the third orange bar, functional independence. The ability for someone to do what they want to do. Light housework, getting dressed, showering, their own personal finances. That takes a peak VO2 of about 18 mLs per minute per kilogram. So we're talking about a very big disease population, many of whom are so limited that they are reliant on others to do what they want to do in their routine daily activities. So the question then comes, why? Why are they so limited? And relevant to this talk, what can we do about it? So the outline, I'm going to be talking about therapies that predominantly impact central reserve. When we talk about central, we're really meaning the heart itself. I'll talk about heart rate, a little bit on stroke volume, but also this concept of elevated filling pressures leading to premature cessation of exercise. I'll then transition over and talk about peripheral oxygen utilization. We'll talk a lot about the AVO2 difference, a marker of skeletal muscle oxygen utilization. There's awesome preclinical data out there, but that's not going to be the focus of this talk. We're talking just about human studies and human data focused on exercise, not on endpoints. And this is still a big field. So I called this down to be what's hot in the field of HFpEF right now. I'm happy to talk about other stuff in older studies, but you'll see the eye is on the newer things that are coming. I will be talking about off-label use of novel agents, and I'll have some unpublished preliminary data that I'll share with you. So just by way of basics, this is the cardiovascular response to exercise. When you start to move and shake, your VO2 can increase dramatically. And this is driven by an increase not only in cardiac output, more squeezing, but also in the AVO2 difference, the ability of your muscles to take up that oxygen and use it. Now, when we look at cardiac output, that's stroke volume times heart rate, you see that the dynamic range for stroke volume, it's not as much as the other ones. It's about 40%. And so comparatively little work has gone into that metric, but certainly heart rate reserve going up dramatically and the AVO2 difference reserve going up dramatically. These are important features of the cardiovascular response that make it so that we can augment our oxygen utilization from about 3 mLs per minute per kilogram when we're at rest up to 45, 50, even higher in peak endurance trained athletes. So let me get into the central limitations. For many, many years, we've known about this intimate relationship between heart rate and VO2. The higher you push the heart rate, the higher the VO2. And that's been shown in many different studies, different patient populations. But this begs the question then, is that the issue? Can I just push the heart rate more? And would that help in terms of VO2? And from early on, we saw that there seemed to be abnormalities in heart rate augmentation in HFpEF patients. On the left is data from Barry Borlaug's group. He'll come up quite a bit. The Mayo Clinic has done a lot of the key trials in this space. But in this study, this is just in black control and in white HFpEF, your ability to increase your heart rate from rest to 20 watts of exercise. And what you see is that in control, the column is higher than in HFpEF. HFpEF patients just weren't able to increase the heart rate as much. And when you look on the right, this is just looking at that first brief moments of exercise, acceleration of the heart rate increase. It's a bit sluggish in HFpEF patients as compared to controls. And these and lots of other data have brought up the concept, can we modulate heart rate and in doing so, improve exercise capacity? Probably the best data to suggest that idea comes from this study that was published relatively recently, a beta blocker withdrawal study. So I'll go through how they designed this. This was 50 some odd individuals, all of whom were on a beta blocker and all of whom, when they exercised, demonstrated chronotropic incompetence, a chronotropic index less than 62%. Those individuals were then randomized to beta blocker continuation or beta blocker withdrawal in a crossover fashion. And what you see on the right is that when you took away that individual's beta blocker, they did much better, a 2 ml per minute per kilogram increase in peak VO2. And remembering they're starting out much lower, 12, 14, that too is actually a pretty substantial difference. The trouble though is that beta blockers do a lot of things. They don't just do heart rate. They impact the vasculature, they impact contractility, they do many other things. So really what the field was waiting for was a pacing study, a study that was purely looking at heart rate modulation. And it turns out that that study was quite hard to do. Many had tried and then had to stop the study due to poor enrollment. But just this year, Dr. Borlaug's group published the Rapid HF study. In this study, about 30 HFpEF patients, symptomatic HFpEF. And again, they all had to have chronotropic incompetence. If you were on a beta blocker, the index was 0.62. If you were not on a beta blocker, a chronotropic index of 0.8. So a standardized way to say, yeah, this is a HFpEF patient, they have symptoms, they have chronotropic incompetence. These individuals were then implanted with a pacemaker, and they were randomized in a crossover fashion to pacing during activity being on or pacing during activity being off. They didn't modulate the resting heart rate in this. So did the intervention work? It did at rest, pacing on versus pacing off. You weren't designed to pace at rest, so the heart rate is the same at rest. But with exercise, yeah, the heart rate was faster. They programmed the devices so that when people were doing things, the pacemaker would take over, atrially pace, drive the heart rate faster than when the pacemaker was off. And that was true at submaximal exercise, the anaerobic threshold or ventilatory threshold, the landmark in exercise capacity, but also true at peak on the far right. But it didn't make a difference. If you look on the right, you see that VO2, either at the anaerobic threshold or at peak, was no different at all. In fact, they measured cardiac output using this technique called acetylene rebreathing. And what they found is if you increase the heart rate, the stroke volume would go down, cardiac output was no different. So this study was a huge bummer and really, has brought into question whether or not this tactic can work. But it's still being studied. I put up here the other ongoing trials right now in pacing. People looking at things like CRT amongst others. Maybe there's another way that we could be doing it. But let me transition to this other main concept in heart failure with preserved ejection fraction. The hypothesis that a rise in the wedge pressure in of itself leads to premature cessation of exercise. And of course, the wedge pressure rise is very important in HFpEF. It is in fact diagnostic of the condition. You have someone who has shortness of breath, many common comorbidities of HFpEF, extra weight, hypertension, etc. You do a workup, echo, stress, all the things, and you don't know why they're short of breath. If available to you, you do an exercise right heart cath. It is diagnostic if the pressures rise more than they ought to, typically defined as a rise greater than 25 millimeters of mercury. That's diagnostic of HFpEF. And on the left are data from Dr. Borlaug's group saying that even in individuals who at rest had normal filling pressures, when you do something to a HFpEF patient, just put their legs up in the cath room table, for example, mild perturbations to the system, you get a much more dramatic increase in the wedge pressure. And if you ask them to exercise, which really stresses the system, now the wedge pressure goes up even more. On the right, this is what Dr. Lewis's group in Boston at Mass General has expanded on this concept and said, let's not just use one point in time, let's form a relationship between the rise in the wedge pressure and the rise in the cardiac output, multi-point. And you show that in HFpEF patients, the slope of that rise is much steeper than in control individuals. And the rise in the wedge pressure correlates with exercise capacity. The higher it goes, the lower the peak VO2. That's shown on the left. And on the right, it's also shown that that's true regardless of the position you test the individual in. Whether you have them doing upright exercise, some labs can put in catheters and do upright exercise, but it's more common to have someone supine on the cath lab table, do exercise on the cath lab table while we measure the pressures. But in both instances, the relationship between the wedge and the VO2 hold. And this all comes together for the hypothesis that the rise in the wedge pressure is driving shortness of breath, leading to premature cessation of exercise. So we're going to talk about that in the next portion of the talk. There are many possible ways to lower the wedge pressure. And I've listed a couple that I thought of here. I'm not going to go through all of them, although I am happy to talk about others that we don't have time. Again, focusing on the things that are hot right now in HFpEF gives us the top 5 issues. I've already talked about heart rate. So I'll move on from that to contractility modulation. The idea here is the heart is a pump. If I can get that pump to squeeze more and empty down, maybe that would lower the wedge pressure. And that's been studied with a drug called levosimendan. Levosimendan is a very interesting agent. It's a calcium sensitizer. It binds to troponin, enhances the interaction between actin and myosin. It also has vasodilatory properties as well. As shown on the right, in decompensated HFrEF, levosimendan increases cardiac index and decreases the wedge pressure. So with that background, a study was formed, the HELP trial, levosimendan in PH, pulmonary hypertension, HFpEF. And the design here is cool. What they did was they took individuals, you came to the cath lab, and you had an exercise hemodynamic study. Then you stayed in the hospital for 24 hours and received an IV infusion of levosimendan. You came back to the cath lab, and you did another exercise study. Only individuals who showed a drop in their wedge pressure at 25 watts of at least 4 millimeters mercury were allowed to be randomized into the study. So you had to be a levosimendan responder following a 24-hour infusion to make it into the study. You were then randomized to 6 weeks of IV levosimendan via PIC versus placebo. You came back in and did another exercise hemodynamic study with the wedge pressure at 25 watts being the primary endpoint. Here is what they found. So I'll walk you through this. Blue is the baseline study before you get any drug. The red triangles are after 24 hours, your initial infusion. Of course, the red triangles have to be lower than the blue dots, or you wouldn't have made it into the study. But the black squares tell a different story. That's after the 6 weeks. And after the 6 weeks, if you look, there's no difference at 25 watt wedge pressure between people who got the 6 weeks of levosimendan versus placebo. Now, the authors have gone back and looked at this and said, well, okay, let's not just look at the 25 watt time point. Let's use all of the wedge pressures. And when you do that, you do see a reduction in the wedge pressure. And as shown on the right, there was an increase in 6-minute walk distance of about 30 meters. That's the cutoff for clinically significant improvements for 6-minute walk. So an oral formulation of levosimendan is now available and is being trialed in the LEVEL study. So story's not done yet. What else can you do? Well, you could decrease venous return. Again, the pump, you would lower the pressures in the pump if you're able to decrease the amount of blood coming back to the pump, for example. And that's the hypothesis behind a very hot topic right now called splanchnic nerve modulation. The idea here is that a lot of our blood volume exists within the venous system, and of that, much of it is around your guts, liver, spleen, the blood vessels around your intestines. This matters because when you start to exercise, these blood vessels are very richly sympathetically innervated, tone increases, and it squeezes blood back into central circulation. What if you could interrupt that? Is it possible that you can interrupt that enough so that you don't crush preload, but interrupt it enough so that you don't get this marked rise in the wedge pressure? On the right is a pilot study, 11 individuals with HFpEF who actually underwent surgical excision of the right greater splanchnic, surgical now. And what you can see is as compared to baseline at follow-up time points, 1 month, 3 months, and 12 months, I'm showing you the 3-month data here, the wedge pressure with exercise was reduced, and they did find a reduction, an improvement in peak VO2. But of course, that's very invasive. So people have been working on developing transcatheter ways of going about this. And this is work that Marat Foudin at Duke has really been doing a lot of great stuff with. And he shared this slide with me, which was presented at HFSA just last month, not yet published, so considered preliminary, but was presented at the conference for Rebalance HF, a sham-controlled study. 40 some odd individuals received the actual procedure where they ablated the nerve. 40 some odd patients had a sham procedure. And they brought them back and they did exercise hemodynamics. The primary endpoint was the difference in wedge at these time points, legs up and 20 watts. And unfortunately, no difference with this technique in a sham controlled trial. But again, probably not the end of the story, probably not. I know that they're working on trying to look into this subset, look into this data more. Is there a subset that would benefit? Can we find a responder group? Another way the pump could maybe get to lower pressures is if you were able to increase the rate of relaxation after contraction. And we know that that's abnormal in HFpEF. If you look at the time constant of isovolumic relaxation in the cath lab, something called tau, it is prolonged in HFpEF individuals as compared to controls. And there's many reasons why. I'll take some liberties in my discussion of this. But one is the reminder that the heart is extremely energetically demanding, goes through a lot of ATP. And that ATP serves many purposes, but the main ones are, of course, for contraction. You need ATP to come in to lead to that release of myosin and the resetting of its head for the next cross-bridge formation and power stroke. But you also need ATP for the ion channels, the sodium, potassium, ATPase, the circuit 2A channel, and other calcium pumps that exist on the membrane and kick calcium out of the system. There's some evidence that perhaps there are abnormalities in this process. This was a biopsy study that was done. These are individuals on the left here who were undergoing CABG, and they took a strip of the heart at the time of the CABG. 36 controls, 29 with hypertensive heart disease, and 19 with hypertensive heart disease and HFpEF. They paced these strips of heart, and then they watched them relax. And when they did this, they found that the patients who had HFpEF had slowed relaxation as compared to the other groups. They found higher resting calcium and a decrease in the recovery of diastolic calcium. Now, I just mentioned that diastolic calcium fluxes are incredibly energetically demanding. So is it possible that there's an energetic deficit that may be related to these problems? And there's some data to suggest that maybe that's the case. On the left, you're looking at resting myocardial phosphocreatine to ATP ratio. You get this with 31P spectroscopy imaging. And the phosphocreatine to ATP ratio is really a marker of energetic status where low is bad. And what they saw in this study was that when you did it, patients with HFpEF had a lower phosphocreatine to ATP ratio within the myocardium. What else they did in this study, which is pretty cool, is that they studied these individuals during exercise using radionuclide ventriculography, where they tag the red blood cells, they have the person exercise, and then they follow the red blood cells into the ventricles. And in doing so, you can learn about the peak filling rate and the time to peak filling amongst other diastolic parameters. What they showed on radionuclide ventriculography at a set point, 50% of heart rate reserve, were that these HFpEF patients had slower filling times and it took longer to get to peak filling. So now you have this energetic deficit being shown to you in the terms of this phosphocreatine to ATP ratio and this diastolic impairment, suggesting that perhaps these two things might be related. So what can we do about it? What are potential avenues? Well, SGLT2 inhibitors, they're hot in cardiology. We're trying them in every which way we can. And so people started looking at them for this purpose. There are many reasons to think SGLT2 inhibitors may impact energetics. I put it up here. This is a talk in of itself. Another day goes by and there's another paper about a potential SGLT2 inhibitor mechanism. But this was still the background behind a trial called EMPA Vision. And EMPA-Vision took about 40 some odd patients with HFrEF, 40 some odd patients with HFpEF, and randomized them to empagliflozin for 12 weeks versus placebo. And the primary endpoint was that phosphocreatine to ATP ratio on MRI spectroscopy. Unfortunately, after 12 weeks, it made no difference. On the left are the HFrEF patients. You see that across the board, there were no changes in the phosphocreatine to ATP ratio. And on the right, in HFpEF, also no relationship. And there may be things about this study that could be more nuanced to explain it. The phosphocreatine to ATP ratios were actually fairly normal to begin with, but regardless, it was a neutral study. Perhaps not surprisingly then, they also looked at peak VO2, and empagliflozin made no difference. This is looking at that data in HFpEF on the right, the red bars. Empagliflozin didn't move the needle at all on peak VO2. So what about passive stiffness? We're talking about relaxation. We just talked about active relaxation, soaking up that calcium. Passive stiffness is a different process, the actual stiffness of the cardiomyocytes itself. And this is where the nitric oxide story comes in. Nitric oxide does many things, so I will boil it down to the level that I understand it in, and that is that nitric oxide activates soluble guanylate cyclase. That leads to a lot of cyclic G. Cyclic G does many things, one of which is activate PKG, and PKG does many things, one of which is modify titin and alter its stiffness. And there are data on cardiomyocytes that HFpEF cardiomyocytes are stiffer. This is shown here. When you look at cardiomyocytes in HFpEF versus REF versus AS, you see that it's stiffer. You add PKG and that goes down. And PKG activity here reduced in HFpEF as compared to the control groups with lower levels of cyclic G. Now, I don't need to review this too long. Our current studies that have attempted to modulate nitric oxide in HFpEF have not really panned out the way we hoped they would have panned out. Many neutral studies. But a question comes is, well, maybe we've been augmenting NO. Maybe we need to be thinking about a different way to augment NO. So in the classic pathway, L-arginine in the presence of molecular oxygen is acted upon by nitric oxide synthase enzymes to yield NO. It's a pathway that is oxygen dependent. On the other hand, increasingly, we've been learning and studying about a complementary pathway on the right. And this focuses on nitrate and nitrite, inorganic nitrate and nitrite. Now, you can take inorganic nitrate in from a diet that is rich in green leafy vegetables, things like arugula or even beets. It gets rapidly absorbed in your GI tract. For reasons that we don't know, it gets concentrated in the salivary glands and injected onto the back of your tongue, where facultative anaerobes there reduce that nitrate to nitrite. The nitrite then gets absorbed in your GI tract. And what's unique is that the nitrite will float around and it gets selectively converted to nitric oxide, but that much more preferentially happens in the setting of hypoxia and in the setting of acidosis, settings like exercise. And I'll come back to that idea. So people have been wondering, maybe we need to be looking at inorganic nitrate and nitrite. And this is work from Dr. Borlaug's group, 2 studies showing that whether you give inorganic nitrite infused or inhaled, taking advantage of the large pulmonary capillary bed, inorganic nitrite reduced exercise wedge pressure. Unfortunately, though, that led to the HFpEF study, which was patently neutral. When you gave HFpEF patients inhaled nitrite 3 times daily in a crossover fashion for 4 weeks at a time, it made no difference at all on peak VO2. Again, the story is not written. There are several other studies that are exploring this, and we'll hear more about it. It remains a hot topic in the field. Now, there are other things that are out there, but I'm going to pause here because of other data that have recently come up. This is fantastic data that came from Ben Levine's group just recently that really has challenged the concept that a rise in the wedge pressure is limiting exercise. What they did here was they took patients with HFpEF, they exercised them, and while exercising them, they sprayed nitroglycerin onto their tongue. What they showed was that if you do that, you do in fact lower the wedge pressure. But there was no difference at all in peak VO2. Lower the wedge pressure made no difference on their peak VO2. Another study that recently came out from Dr. Borlaug's lab, a different lab, looking at the hemodynamic effects of dapagliflozin. They wanted to see, did dapagliflozin alter hemodynamics at rest and with exercise? And as shown on the left, it actually did. Dapagliflozin lowered the wedge pressure at rest, and it lowered the wedge pressure with exercise, about 5 millimeters mercury. But it made no difference on peak VO2. And these recent data are starting to chip away at this idea that the rise in the wedge pressure is the driver of shortness of breath and exertional intolerance in HFpEF. That's not to say it's not important. In fact, I started by saying it is diagnostic of the condition. But perhaps it could also, at least in some individuals, be a secondary phenomenon. So with that, I'll transition over to the periphery, and we're going to start talking about the muscles, extraction, and utilization. Now, a lot has to happen for your muscles to use oxygen. First, it has to get there, and that involves hemoglobin, involves saturation, involves your blood vessels vasodilating to get blood from central circulation to the skeletal muscle capillary bed. But then that oxygen has to diffuse out of the capillary bed and ultimately make its way into the mitochondria. There, the mitochondria take that oxygen, combine it with substrate to yield ATP. And then that ATP needs to leave the mito, get back out to the sarcomeres, and do work. So a lot of steps have to happen. To date, the only therapy that has consistently shown a benefit in HFpEF in terms of exercise is exercise training. These data started with Delane Kitzman at Wake Forest. Many other groups have shown similar finding as well. You take HFpEF patients, you do aerobic conditioning for 12 to 16 weeks. Peak VO2 goes up by about 2 to 3 millimeters of mercury pretty consistently across many different studies. But what's fascinating is if you study these patients before and after the intervention. And in this paper that was done with Mark Kikowski and Delane Kitzman, they did just that. When they studied them, cardiac output in the training group was no different at peak from baseline to follow-up. But what was markedly different was the peak VO2. And in fact, the rise in the peak VO2 with exercise training explained nearly 90% of the increase in peak VO2 that they were able to demonstrate. So what's going on in HFpEF in terms of the skeletal muscle and in terms of the AVO2 difference? What do we know about it? Well, it turns out that there are data to suggest that there's a problem here. This was a paper from the Boston group where they first plotted the black line. And that black line is the control line. That line is taking their patients who didn't have HFpEF, didn't have manifest cardiovascular disease, and plotting what the AVO2 difference should be for any given cardiac output. Make that control line. They then plotted these data for HFpEF studies in which they were available. And what you see is that across the board, the HFpEF dots lie below the control line, suggesting that there's a systematic abnormality in the AVO2 difference. For any given cardiac output, the AVO2 difference is lower in HFpEF than it ought to be, suggesting there's something wrong with skeletal muscle oxygen utilization. Now, the trouble is the AVO2 difference is actually quite complicated. We learn the Fick principle that VO2 is equal to the AVO2 difference times cardiac output. And the way that we all learn it almost seems to imply that these are independent phenomena. You double the cardiac output, you double the AVO2 difference. But it turns out that that's not correct. And we've known that that's not right for years. On the left are data from Peter Wagner, who is like a gigantic figure in the landscape of human physiology, and he was one of my K mentors. He did some of the work that showed that if you increase cardiac output and oxygen delivery, of course, VO2 begins to rise. But it doesn't continue to do so. There's an inflection point in this relationship where now, yes, if you keep on increasing O2 delivery, you get diminishing returns in terms of your VO2. Why is that? Because you start to impair extraction. Convective O2 transport tells us about our ability to get oxygen to the skeletal muscle capillary bed. How good you are not only at taking that cardiac output, but distributing it across the arterial system to vasodilate to get the blood to the muscle. But what can't be forgotten is that once that blood is at the muscle, that oxygen within that capillary needs to diffuse out of the red blood cell and ultimately make it to the mitochondria. If you increase convective transport and you continue to do so, you begin to compromise capillary transit time. And in doing so, you impair diffusion. You impair the ability, excuse me, of oxygen to leave the capillary bed to get into the mitochondria. So what governs diffusion? Well, it can be summarized by this lumped parameter called DMO2, the diffusional conductance for oxygen at the skeletal muscle. Many of the parameters that are involved in its derivation are intuitive. The more mito you have, the more capillaries you have near the mito, shortening that distance between the two, that improves diffusion. And then there are functional things within the capillary itself. Turns out within our capillaries, there's something called a glycocalyx that modulates the relative rate of plasma going across versus red blood cells going across. So you can modulate capillary hemoglobin. So there's these properties that come together into DMO2. And this concept, pioneered by Peter Wagner, seeks to answer the question, why is it in humans we don't increase peak VO2 by just extracting more? Why is it that we don't just keep pulling down the AVO2 difference, or rather, keep pulling up the AVO2 difference by lowering the venous O2 content? Why don't we just do that and increase peak VO2 as a result? The answer to that is because if you were to do that, you would lower venous O2 tension, you would ultimately lower capillary O2 tension, and in doing so, you would compromise the diffusion gradient for that oxygen to leave the capillary bed and to get into the mitochondria. And so this is a Wagner diagram where we've plotted first the Fick principle. This is what we know, flow times the AVO2 difference. What is less discussed is Fick's law of diffusion, which is DMO2 times the partial pressure of oxygen within the capillary bed. These two cross to give us VO2 max. But DMO2 is pretty important still. In fact, if you reduce the slope of that line, which is what DMO2 is, you get a marked reduction in VO2, even if you don't change anything in terms of oxygen delivery. So we sought to look into this. We sought to study diffusional conductance in HFpEF patients. To date, the bulk of the studies that have been done have used leg catheterization with bike exercise. These were fantastic physiologic studies, but people don't like catheters in their groin. They certainly don't like exercising with catheters in their groin. And so the studies were smaller in the number of patients, almost by design, and more invasive. So we set out to say, well, can we do this across the forearm? We know HFpEF is a systemic disease. Can we do it that way? And we developed a technique for measuring DMO2 across the forearm. It involved serial sampling of arterial blood gas, ABGs, the placement of a catheter retrograde within one of the deep draining veins so that while you're doing forearm hand grip exercise, we are withdrawing blood that is coming from that skeletal bed, and brachial ultrasound telling us about flow. And the concept here is that you're really solving two linear differential equations. You know what arterial and CO2 content is on the arterial side from an ABG. You know what the final arterial and CO2 content is on the venous side from your serial sampling. You know flow because you're getting it through brachial ultrasound. And so you do an iterative process in which you modulate DMO2 so that the observed values match the expected values, and that's how you get it. When we did this, we found that the AVO2 difference across the forearm was abnormal in HFpEF patients. HFpEF being the red line. These were two control groups, healthy individuals across a range of ages, hypertensive individuals who were similarly aged to the HFpEF group, but didn't have heart failure. When we looked at that, the AVO2 difference for any given brachial flow was reduced. But when we solved for DMO2, it's probably best seen here, where I mentioned to you the slope of this line is proportional to DMO2. There was no difference. We found no difference in DMO2 across the forearm skeletal muscle capillary bed. So I have an abnormal AVO2 difference, but DMO2 can't be the answer. So that got us thinking more and more about what the mito are doing with the oxygen as it comes across. And it turns out there are some data about skeletal muscle OXPHOS, oxidative phosphorylation capacity. These data are from Bob Weiss's group, again, 31P spectroscopy, exercising within the MRI scanner. When you do this, phosphocreatine goes down with exercise. It goes down because if you look at the phosphocreatine shuttle, phosphocreatine gives up its high energy phosphate to ADP being generated during exercise to yield free creatine and ATP. At the cessation of exercise here, the reaction is pushed towards the generation of phosphocreatine because now the mito are making ATP and they push the reaction in the other direction. So the recovery time, the recovery constant here is an index of skeletal muscle OXPHOS. When they did this, they found that in HFpEF patients, it was prolonged, certainly as compared to asymptomatic HFrEF or healthy individuals. Now, we sought to study that a little bit further. We used a different technique at UPenn called creatine chemical exchange saturation transfer. And the value here is that as opposed to imaging 31P and using that system, we're imaging free creatine. You can get a lot better spatial resolution. So this is a calf. Here it is at rest, not much red. You then exercise the person for 2 minutes under a standardized exercise protocol. You get lots of red, a reflection of free creatine, because we pushed that reaction this way towards creatine generation. But every 30 seconds, free creatine levels go down. And just as before, you can model this creatine recovery halftime. And when we did that, it was prolonged in HFpEF individuals as compared to the two control groups. Moreover, that recovery halftime correlated with systemic exercise capacity, drawing this link between what's going on in the skeletal muscle being a determinant, correlative of your peak VO2. Now, we want to look into this even further. So we called our participants back and said, listen, I'd like to biopsy you. And actually about half the participants agreed to do so, 10 HFpEF patients, 10 hypertensives, 10 controls, give or take about that number. And we biopsied their thigh. We did the thigh because this is the traditional research biopsy site. Not much here that can get you into the trouble. I bring this up because I showed you an MRI of the calf, but now I'm going to be showing you what we found in the thigh. They're both locomotives, but take that in mind. So when I compared HFpEF to hypertensives, 10 and 10 in the group, using mass spec, we were able to identify about 3,000 proteins. And of these, about 10% were different, 300 proteins. We then took these proteins and put them through a pathway analysis system and said, well, what are they? What are they clustering towards? And what you find is that by and large, these are the proteins that are related to the generation of enzymes of energy. These are the proteins of the TCA cycle, the electron transport chain, and the complexes more than anything else. So we're seeing in HFpEF a relative reduction in the proteins of energy and fuel metabolism. So you have this functional endpoint, the MRI, that's correlating with systemic exercise capacity, and then on biopsy, a reduction of the proteins that are related in this process. So with that, I'll transition to just the last part of the talk and saying, well, what can we do about it? So, a side note, this is an awesome website. I was looking up figures for this talk. I know nothing about how cars work. These graphics are amazing. So just as a side note, if you get bored, click on them. My simplification in thinking about the skeletal muscle as an engine. That skeletal muscle needs to get fuel. You don't got fuel, you're not going anywhere. And then there needs to be a spark. Something has to trigger that fuel to lead to combustion. We're going to talk about fuel and we're going to talk about ignition. And actually, it turns out that there are data to suggest that there's an abnormality getting fuel to the skeletal muscle in HFpEF. On the left, this is with Dr. Borlaug's group showing the vasodilatory reserve. The systemic vasodilatory reserve doesn't go down as much in HFpEF patients as in controls. But a really elegant study done by the Utah group, who probably does some of the best studies on vascular conductance. They took HFpEF patients and did single leg kick exercise and showed that when you did this, you weren't able to increase blood flow as much in the HFpEF patients as compared to the other groups. So signals that maybe exercise blood flow may be impaired. Now, remembering back, we talked about inorganic nitrite. When you infuse inorganic nitrite into the brachial artery, it increases blood flow through the generation of nitric oxide. And when you do it while you ask someone to exercise, it becomes much more so with even more NO generation, the black line on the far right. So we sought to wonder whether or not giving inorganic nitrate could improve exercise in HFpEF. This is a study that we did now some time ago, in which we took 17 HFpEF individuals, we brought them in and we exercised. And then a week later, we brought them back in and we did it again. The only difference is one time before they exercised, they got a big old dose of beetroot juice. And the other time they got a placebo. It was beet juice, but the inorganic nitrate had been removed. And here's what we found. Peak VO2 in this crossover study increased by about 12%. That was driven by an improvement in the vasodilatory reserve. You were able to vasodilate your blood vessels more, presumably to get more blood to the muscles, and there was an increase in cardiac output. So that led to the knockout trial, where Julio Chirinos, one of my mentors and colleagues of the last 15 years at Penn, he was the main site PI. I was the Penn site PI. This was a study that we did along with Northwestern and Sanjeev Shah of 84 individuals with HFpEF in a crossover design, getting randomized to KNO3 versus KCL. The study is done. We're tabulating the results, primary endpoint being peak VO2 and total work performed. Now, not only getting fuel there is important, but the type of fuel may matter, that octane idea. And that's my segue into ketones. Again, all the rage right now in the vaguely defined health and wellness space, but also in other spheres as well. Ketones may potentially be a better fuel source for your skeletal muscles, at least acutely, never mind their long-term signaling effects. And that is, perhaps there's an energetic advantage of using ketone as a substrate, certainly over glucose and possibly over fatty acids as well. Ketones provide acetyl-CoA that goes into the TCA cycle. Magic happens and you get ATP. But does providing this alternative fuel source improve exercise in HFpEF? That's another study that we recently completed. 20 individuals with HFpEF came in, very similar to what you've heard. They exercised for us. They came back in a week later. They did it again. The only difference is on one of the days, they get a lot of exogenous ketone. On the other day, they got a placebo that our dietary core made that tasted terrible. So we'll find out whether it made any difference as we now tabulate these results. The last concept I mentioned was the spark idea and the mitochondria. At the end of the day, you get fuel there. You get oxygen there. You got everything there ready. But if there isn't good mitochondrial function to take these substrate and make ATP, you're going to be out of luck. Now, mitochondrial function is a gigantic topic in of itself, but there's been increasing interest in NAD in some of these molecules. Now, NAD comes up because it sits almost in the middle of many biochemical pathways. You need NAD to be present for glycolysis. You need it to be present for beta oxidation. You need it to be present for the TCA cycle. And in its reduced form, it's what gives the electrons to the transport chain to ultimately give us ATP. And there are some data that NAD may be abnormal in HFpEF. On the left is cardiac NAD being reduced in a small number of hearts, 12 HFpEF hearts versus 10 non-failing hearts. On the right, NAMPT, a key enzyme in NAD salvage that helps to keep the NAD levels up, reduced in HFpEF as compared to controls. And I'll share that in our own hands in the skeletal muscle, this is some preliminary unpublished data, NAD was reduced in HFpEF in the muscle itself as compared to control groups. We also found reductions in 2 other bioenergetic molecules, propionyl-CoA and acetylcarnitine, but I'll save that for another time. And so that led to an R01 that we have right now, looking at whether or not we can use these interventions to increase exercise in HFpEF. And the idea is that some individuals, maybe the problem is they just need a better way of getting oxygen to the muscle. Their mito were fine, but they just have to find a little more support to get oxygen there. So beetroot or KNO3, the pills of the beetroot juice. Then there may be individuals who have problems with the mito in addition to blood flow. In those individuals, if you increase blood flow to the muscle, you might have some improvement, but you'll have more improvement if you also bolster mitochondrial function. So a second group is KNO3 combined with nicotinamide riboside, an NAD precursor, and propionyl L-carnitine, giving propionyl-CoA for anaplerotic substrate and acetylcarnitine as well. And then finally, active control. So people go through this, a 3-period crossover study, in which after every period we do the testing that I've already mentioned to you today, the bike stuff, the MRI stuff, and the biopsies. But at the end of the day, we don't know why patients with HFpEF are so limited. And there's a feeling that maybe we need to be looking and really defining subgroups. And so there's a movement called HeartShare. It's led by Sanjeev Shah at Northwestern. 6 clinical sites, Penn is one of them. The endeavor is to deeply phenotype nearly 750 HFpEF patients with 2 days of testing, CPETs, MRIs, CT scans, PFTs, blood work, you name it, under the hopes that we can take all of this data and using bioinformatics, get different groups of HFpEF patients, and then these groups would be targeted down the road. So this is another massive endeavor that is underway right now to understand exertional intolerance in HFpEF. So with that, the most important slide, my kids, and I'm happy to take any questions. And thank you guys for listening. Oh, the CME code. Yeah.
Thank you very much, Dr. Zamani, for the wonderful talk. So we're able to take questions now. Good.
Sure. So, great talk. I think that the early data that you were mentioning as far as exercise and changing sort of functional outcomes. I'm just curious if I don't know anything about this space. Has there been any interest in looking at specifically like resistance training, because it seems to tie in a lot with skeletal muscle?
Yeah, resistance training is fascinating and probably totally underutilized in the United States in general. There was one comprehensive study that looked at it by Ryan Pitzman's group called Secrets 2. The short version of the story is like this. They published a study called Secrets, and Secrets was 100 individuals who had HFpEF, and they got randomized in a 2x2 factorial design to exercise and diet. And in Secrets, they showed that exercise increased peak VO2 and diet increased peak VO2. Great. The trouble was when you looked at the diet group lost muscle. And in fact, if you look at almost any weight loss intervention, about 20 to 30% of the weight that you lose with a weight loss intervention is lean body mass. And so Secrets 2 was published where they did diet, exercise versus diet, exercise, resistance training. What they found there was that resistance training led to bigger muscles, but it did not change peak VO2. There's one other study recently published that has looked at resistance training alone in HFpEF. It was published in the Journal of Cardiac Failure, I think last month or something like that. But in general, there's much less data on resistance training, not just within HFpEF, within the sphere of cardiac rehab, that aortic condition. But there's reason to think it could be very important.
So Manny, we have another question on Zoom. So this is from Puriya Shureshi. He's one of our research fellows. His question is to do with the part that suggests reducing venous return during exercise by decreasing sympathetic tone as a potential solution to lowering PC wedge pressure. So he's asking, I'm curious if there have been any studies evaluating the impact of stimulating vagal efferent during exercise to reduce both wedge pressure and exercise tolerance in this subset of patients.
There are interest in modulating vagal tone, certainly in the HFrEF space. I can't think of anything published in the HF space right now. But I'm sure companies that are looking at it in HFrEF have considered it in PEF as well. But I can't speak to that more.
Thank you. And there's another question by Dr. Abate. So he's asking if there's any role for systemic inflammation.
It's a fascinating question. Given the asker of the question, the answer can't be no. So that's that. But we know that these comorbid conditions that patients suffer from, we know that they are tied, whether they're causative, we don't know. They are tied with increased inflammation. And that may be part of the problem. And recent data from HFpEF, that was a gigantic trial in which, not gigantic, 526 patients with HFpEF were randomized to semaglutide versus placebo. And they found weight loss and increased 6-minute walk, but they also found a reduction in CRP. And that's interesting. That gets at the idea that maybe these comorbid conditions like excess adiposity are really drivers of the disease and not bystanders. Mm-hmm. What we don't know as well is if you just target the inflammation and not the comorbidity, will you still get the same bang for your buck? It's just not known.
Unless there are any other questions, we'll finish over here. Thank you so much, Dr. Zamani, for the wonderful talk, and thank you for joining us this morning.
Thank you.